Much of what we learn about agents that leads to their approval doesn't tell us much about how we're going to use those drugs in clinical practice. And as we try and move drugs into the earlier time frame in the metastatic setting and into the adjuvant setting from a metastatic trial, we really need to understand what the potential benefits are of these agents, and also, or ways of treating patients, and also what the potential toxicities are. So B-38 actually randomized patients with node-positive early-stage breast cancer, almost 5,000, to receive either TAC chemotherapy for 6 cycles or Dosdense AC followed by paclitaxel with or without gemcitabine. And that trial, actually very interesting. Everybody received growth factors. There was absolutely no difference in the comparisons that were planned in the trial, which was to look to see whether or not the addition of gemcitabine improved outcome compared to either TAC or AC followed by paclitaxel dose dense, and it didn't. And the second thing was to see whether or not it was better to give all your drugs together, TAC, or sequentially AC followed by paclitaxel, and there was no difference there either. In addition, which was kind of interesting, the toxicity, if you just looked at the number of patients who had, grade 3 or more toxicity, was relatively similar, but the toxicities were different, with more diarrhea and febrile neutropenia in patients receiving TAC, and more neuropathy and anemia in patients receiving the sequential chemotherapy arms. The other interesting thing is if you give more chemo, like you gave AC followed by paclitaxel and gemcitabine, there was more anemia, more need for transfusions, and more use of erythroid growth factors.